Hello friends, welcome back. Today we will be discussing about the follicular carcinoma of the thyroid. We have already discussed about the papillary carcinoma, and today we will be discussing about the follicular carcinoma of the thyroid. Now this is also a malignant tumor, and the tumor cells will be showing the follicular cell differentiation, but typically they don't have any nuclear features like what we see in the papillary carcinoma. If you remember, in the papillary carcinoma thyroid there was the nuclear grooving, pseudo inclusions, and all the typical features of papillary carcinoma will be absent, but tumor cells will be showing the follicular cell differentiation. Now this accounts for 5 to 15% of the primary thyroid carcinomas. The most commonest one is papillary carcinoma in the thyroid, and the next common malignancy in the thyroid is follicular carcinoma. And this arises in the areas where we have a diethyroid deficiency, and also associated cause what they have found is exposure to the ionizing radiation. This also can cause the follicular carcinoma, and this is more common in the women, and we see them in the elderly age group. Most commonly the peak incidence is in the 40 to 60 years. Now when we see the localization, it can occur in any part of the thyroid, anywhere in the thyroid gland it can occur. It can also occur in the ectopic thyroid tissue, usually which is present in the mediastinum, or it can occur in the struma ovary. I think you remember this. Even in the papillary carcinoma, it also can arise in the struma ovary. Struma ovary is a type of the teratoma of the ovary. It's a tumor, germ cell tumor teratoma, and in this we have only the thyroid follicles. So when we see only thyroid follicles in the germ cell tumor in the teratoma, we call it as a struma ovary. So in the struma ovary, again there can be development of the follicular carcinoma. Now when we see the genetic alterations which are associated, we have four main genetic alterations in the follicular carcinoma. The first one is the RAS point mutation. This contributes to about 30 to 50% of the cases. And another one is PPARG gene fusion. Now this gene fusion occurs either with the PAX8 or with the CREB3L2 gene. So these fusion genes, they contribute to about 20% to 50% of the follicular carcinoma. Next is about the PIK3CA gain of the function mutation. This contributes about 10% of the follicular carcinoma cases. And the next is about the telomerase reverse transcriptase promoter mutations. Now this contributes to about 20% of the follicular carcinoma cases. So important gene mutations which are associated are, we have two P's. One is PPARG gene fusion, another one is PIK3CA gain of function mutation, and then R is RAS mutation we have, and TERT promoter mutations. This is in the follicular carcinomas. Now just to have a briefing what we have finished, in the papillary carcinoma, the gene mutations what we commonly see is RET rearrangement, then BRAF mutations, and the RAS mutations. Even here also we have the RAS mutations. Now there are certain syndromes also which are associated with the follicular carcinomas. In that we have three main syndromes: Cowden syndrome, Werner syndrome, and the Carnes complex. So in the Cowden syndrome we have PTN tumor suppressor gene mutations. Now in this syndrome the patient, along with the follicular carcinomas, he can develop breast carcinomas, multiple hematomatous polyps in the GIT, and mucocutaneous lesions such as papillomas, palmoplantar keratosis, and trichomoniasis. Whereas Werner syndrome is adult progeria, and the Carnes complex, here we have PRKAR1A gene mutation. Now this Carnes complex, it is characterized by hyperpigmentation and myxomas. There can be cutaneous myxomas or the cardiac myxomas, and patient will also have the tumors of breast, oral mucosa, skin, testis, thyroid, and the pancreas. So these are the three syndromes which are in which follicular carcinomas can arise. So we have four gene mutations, four genetic alterations which were associated, and three syndromes which are associated with the follicular carcinomas. And in 3.7% of the patients will have the family history of the thyroid carcinomas. Now when we see the clinical features, patient typically he doesn't have any specific feature, he just presents with the painless slow growing nodule. Now this nodule on scintigrams, it just presents as a cold nodule, but this follicular carcinoma, it has a hematogenous spread, so very fastly it goes to the bones and the lung. So the most so in some cases the patient may present with the bone fracture. The primary presentation only will be with the fracture or the lung nodules. Then in that we can make out histopathologically that there is a deposit of the follicular carcinoma. So sometimes the presentation need not be as a nodule in the thyroid, but they can present as a bone fracture or the lung nodules. Now when we see the morphology, grossly it presents as an encapsulated lesion, like what we see in the adenomas. The adenomas also present as an encapsulated masses. So when we see in the cut section, this also presents as an encapsulated lesion. The difference is adenomas will have a thin capsule when compared to the carcinomas. Usually when we see in the other organs, adenomas will have a nice capsule, but in the case of the thyroid, if the capsule is thick, then we should suspect that it can be carcinoma. Usually in the adenomas we have a thin capsule, and sometimes you can make out the infiltration also. You can have a small infiltration of the tumor cells into the capsule, and when we see this capsulated lesion, it will be usually minimally invasive, and sometimes we find the lesion which is widely invasive into the parenchyma or into the adjacent soft tissues also. Now the tumor, how it appears is, it will be grey tan pink with focal translucent areas containing colloid filled follicles. So the grossly we can have an encapsulated lesion, or we can have a tan pink colored lesion which is infiltrating into the adjacent thyroid parenchyma and into the soft tissues. We can have some degenerative changes also. If the degenerative changes are present, there can be fibrosis or foci of the calcifications. Now microscopically when we see, there will be uniform appearing cells. They, as I told you, they don't have any specific features like the papillary thyroid carcinoma. They don't have a typical nuclear features, but uniform appearing cells will be present, and there are different patterns like we see in the adenomas. The tumor cells can be arranged as a trabecular pattern, means you have two columns of the cells which will be separated by a thin fibrous septa. So it appears as a this is a trabecular pattern, or it can be a solid pattern also. Then you have a microfollicular pattern where the small follicles will be present. Then it can be a normofollicular pattern, or it can be a macrofollicular pattern where you see a very large follicles, a cystically dilated large follicles. You can see the entire tumor will be composed of macrofollicles only. And another rare pattern is a cribriform pattern. Cribriform pattern means we have a sieve-like spaces, punched out spaces will be present in between the sheets of the cells. So these are the different microscopic patterns what we see in the follicular carcinoma, either trabecular solid, normofollicular, microfollicular, normofollicular, macrofollicular, or it will be cribriform pattern. Now it has been classified, thyroid carcinoma has been classified into three groups. As I told you, it has a very thick capsule, and if we see the infiltration into the capsule, the tumor cells, and they have not infiltrated beyond the capsule, they have just infiltrated into the capsule, then we call it as a minimally invasive, only capsular invasion. Now another one is, we don't find any invasion into the capsule, but still we see the tumor emboli in the vessels. Okay, saying here in the vessels we see the invasion, but the capsule is not infiltrated. Then we call it as an encapsulated angioinvasive. Then third one is widely invasive, where you see the sheets of tumor cells infiltrating into the thyroid parenchyma, and even sometimes these cells will be infiltrating into the adjacent soft tissues. So they classified as minimally invasive, encapsulated angioinvasive, and widely invasive. Now this is the classification which has been given by the WHO in 2017. Now initially they just classified it as a minimally invasive and widely invasive, and in the minimally invasive they have included capsular invasion, with the capsular invasion or with the Vascular invasion. It can be limited vascular invasion when less than 4 vessels are involved, and extensive vascular invasion when more than 4 vessels are involved. So in this way, the AFIP, Armed Forces Institute of Pathology, they have first classified follicular carcinoma as only minimally invasive and widely invasive. Later on in 2017, WHO has classified as minimally invasive when we see only capsular invasion. When we see only vascular invasion, they called it as encapsulated angioinvasive, and then we have a widely invasive. Now the capsular invasion also, when we should call it as a capsular invasion is when we see the tumor cells growing into the capsule in the form of a mushroom. Means the cells have infiltrated the capsule and they are expanding in the capsule. So when they are proliferating within the capsule, they take a shape of the mushroom. So if the invasion is in the form of the mushroom, then only we call it as a capsular invasion. Why this is important is, we can see many patterns which appear as if there is an invasion, but we should not call it as an invasion. Like we have a capsule which is pushed by the tumor cells. Now this should not be taken as a capsular invasion. Or we have a linear break of the capsule with the tumor cells in it. Now this occurs when we do fine needle aspiration. Before going to the biopsy, when we do the fine needle aspiration or surgical procedure for biopsy, the needle track or the core biopsy needle, it will drag some of the tumor cells. So this appears in a linear fashion. So this should not be taken as a capsular invasion. As I told you, we call it as a capsular invasion when we have a mushroom shaped appearance of the tumor cell infiltration. So this also should not be taken as a capsular invasion. Or if we just see a few nests of the tumor cells in the capsule, this also should not be taken as a tumor capsular invasion. Only when we see a continuation with the main tumor and the cells are growing in the form of the mushroom, then only we take it as a capsular invasion. All these things are pseudo-capsular invasion. They are not the capsular invasion. Now next, the vascular invasion. We call it as a vascular invasion when we see the tumor cells in the vessels and they are adherent to the vessel walls. Sometimes it is lined by even the tumor emboli is lined by the endothelial cells. Then only we should call it as a vascular invasion. Or we can see these tumor cells within the thrombus, context of the thrombus or the fibrin. So then also we call it as a vascular invasion. Just the tumor cells lying in the vessels, we don't take it as a vascular invasion. It should be adherent to the vessel wall and it should have an endothelial lining. Now, as I told you, vascular invasion means we should have the thrombi in the tumor emboli in the vessels, and that also the vessels within the capsule or outside the capsule should show the tumor emboli. Then only we consider it as a vascular invasion. If the vessels within the tumor, they show the tumor emboli, we don't consider it as a vascular invasion. We count the vessels with the tumor emboli within the capsule or outside the capsule. That only is considered as a vascular invasion, not the vessels within the capsule showing the emboli. Now the number of vessels we have to count. If the number of vessels involved are less than 4, then it is limited invasion of the vessels. If it is more than 4, it is a just invasion of the vessels, not limited. Now the widely invasive, that was minimally invasive and angioinvasive, encapsulated angioinvasive. Now in the widely invasive follicular thyroid carcinoma, we have the tumor cells which will be invading into the adjacent thyroid parenchyma and into the extrathyroidal soft tissues also. Now we have certain variants in the follicular thyroid carcinoma. First one is a clear cell variant. Now as the name suggests, the tumor cells will have the clear cytoplasm. Now this clear cytoplasm is either because of accumulation of the glycogen, lipid, mucin or the thyroglobulin, and here we call it as a clear cell variant when more than 50% of the tumor cells are the clear cells. Then only we should call it as a clear cell variant. In normal tumors also, in some foci we will be seeing the clear cells, then we should not call it as a clear cell variant. When there is more than 50% of the clear cells, then only we should call it as a clear cell variant. And this accounts for about more than 1% of the thyroid malignancies. And this is more aggressive when compared to the conventional type of the follicular carcinomas. Now, other rare variants, we have a signet ring cell type where you have eccentrically pushed nucleus and a big cytoplasmic big cytoplasmic vacuole, and we have this clusters of the cells will be present, and the stroma in between, it will be showing the extracellular mucin. So this is because the tumor cells have a signet ring cell morphology, we call it as a signet ring cell type. Then we have the glomeruloid pattern, follicular thyroid carcinoma with glomeruloid pattern, where you have the follicles, and these follicles will contain the round epithelial tufts. You are seeing these tufts. So this is the entire follicle, and into the follicle we have the round epithelial tufts which are growing within them, and these structures, they mimic the glomeruli in the kidney. So they call it as a follicular thyroid carcinoma with a glomeruloid pattern. Then we have spindle cell follicular thyroid carcinoma, where we have lots of the spindle shaped tumor cells which are arranged in the intersecting fascicles. So we have 4 variants in the follicular thyroid carcinoma: clear cell variant, signet ring cell variant, follicular thyroid carcinoma with a glomeruloid pattern, and spindle cell follicular thyroid carcinoma. When we see the immunochemistry, the tumor cells will be showing the markers for the follicular cell differentiation. So lineage specific markers are positive, that is thyroglobulin, TTF1 and PAX8. They are positive in the tumor cells, and specifically HbME1 is positive only in the if the follicular carcinoma is present. In some of the follicular carcinoma cases, this marker comes out to be positive. Now, mode of the spread is typically it is hematogenous spread. If you remember papillary carcinoma, it is lymphatic spread, whereas the follicular carcinoma, it is hematogenous spread. So it spreads to the lungs, liver, bone and brain. That's why I told you sometimes the primary presentation can be with the bone fractures or the lung nodules. And in this case, lymphatic spread is rare. Most common is the hematogenous spread. Now, when we see the staging of the tumor, T1 is when the size is less than 2 centimeters in the greatest dimensions and it is limited to the thyroid. T2 is if the size is more than 2 centimeters, less than 4 centimeters in the greatest dimensions and limited to thyroid. T3 is more than 4 centimeters, limited to thyroid, or gross extrathyroidal extension, which is invading only to the strap muscles, not into the major neck structures but only the strap muscles. And T4 is tumor with a gross extrathyroidal extension into the major neck structures, like it goes into the trachea and the esophagus. The major neck structures, if it is infiltrating, then it comes as a T4. Only if the muscles are infiltrating, it comes as T3. If the major neck structures are getting infiltrated, it comes as a T4. Now the prognosis, it depends upon extent of the invasion and the stage of the tumor. Like if it is infiltrating into the neck structures, then obviously the patient will have a very bad prognosis. And obviously the widely invasive carcinomas will have a bad prognosis when compared to minimally invasive follicular carcinomas. And in this also, extensive angio invasion is one of the worst prognostic factor. Now when compared to the invasion into the adjacent neck structures and all that, if the angio invasion is extensive, this is the worst prognostic factor. Now the treatment is total thyroidectomy, which is followed by administration of the radioactive iodine. This is to detect any metastasis is there or and also to ablate the lesions. Then after the total thyroidectomy is done, thyroid hormone is given in order to suppress this endogenous TSH levels, and we have to monitor the patient by estimating the serum thyroglobulin levels. This is used to monitor the tumor recurrence. If there is a recurrence again, then these levels will rise. So this serum thyroglobulin level is used to monitor the tumor recurrence. So that finishes the follicular thyroid carcinoma. Just to have a summary, if you remember the etiological factors we have, this is associated with the deficiency of the iodine, exposure to the ionizing radiations, and we have a genetic alterations. In that we have these 4 genes: RAS mutations, PPARG fusion gene, PIK3CA gain of function mutations, and TERT promoter mutations. So 4 gene mutations are associated. And syndromes, we have 3 syndromes: Cowden syndrome, Werner syndrome, and Carney's complex. So these are the etiological factors. And when we see the age and the sex, women are more commonly affected and in the elderly age group. Sites, as I told you, it can occur anywhere in the thyroid, or it can occur in the ectopic thyroid in the mediastinum and in the struma ovary. Morphology, grossly when we see, it can be encapsulated or it can be widely invasive. And microscopically, again, the same way we have, either it can be minimally invasive or it can be widely invasive, and we have a different patterns: solid or trabecular pattern, microfollicular, normofollicular, macrofollicular, and cribriform pattern. And in this variants we have 4 types: clear cell, signet ring cell type, glomerulite, and the spindle cell type. Now classification, as we have seen, it is either minimally invasive only with capsular invasion, or encapsulated vascular invasion, whether it's less than 4 or more than 4 vessels, limited vascular invasion or not, we have to see. And then widely invasive, where it infiltrates into the thyroid parenchyma and into the extrathyroidal soft tissues. So this finishes about the follicular carcinoma. Thank you friends for bearing with me, though the videos are taking a lot of time for me to make, but definitely I'll be trying to do my videos at a faster level. Thank you friends for bearing with me.